That segues perfectly into our next session and our next colloquium, which will look at some of the reasons why evidence has not necessarily translated into practice. So we're going to be supported by the two Johns, Bob Wells, Sue Lenthall and Paul. Paul's been introduced to you already. Some fun, quick facts. John Humphreys is sometimes mistaken for Gordon Gregory. John Humphreys has worked at Monash, UNE, Swinburne, ANU, La Trobe, JCU and Ohio State Universities. So not only does he provide wisdom in terms of the length of his experience, but he's worked in many of our institutions. John Wakerman has been at Flinders and would be almost eligible for his second lot of long service leave, having been there for nearly 20 years. So I think he needs special commendation for that. Bob Wells has 7 grandchildren, so he can outdo Paul Worley, and in fact 1 great-grandchild on the way. And Paul specifically is fascinated by trains and travelling upon them, and you can talk to him about that. But I love Sue. Sue says she's not very interesting, but she's had a lot of plane accidents, so many people don't like travelling with her. So without further ado, over to John Humphreys to commence the session.
Thanks very much, Jenny, and many thanks for the invitation to participate in this important event today. First of all, I'd like to begin by acknowledging the traditional owners of the land on which we're meeting today, and I would like to pay my respects to elders past and present. My role today is to try and get the IT right, for starters. Is to really set the scene for 3 things. 1, John Wakeman's presentation on what we know, in other words, an expose of some of the evidence. A second session showing some of the success stories we've had where we've actually translated evidence into practice. And a third session led by Bob, looking at discussing what is needed to go forward from this. So I think we can begin with 3 questions really. What is the rural health problem? Do we need more research? And if so, what sort of research? And I want to put this provocative thing of maybe our translation of evidence into policy is not working. Maybe there's a big onus on us as researchers. I want to begin with the rural remote health problem, and I want to take you back 40 years or so. Many of you won't have been born then, but there was an important document that was written by the Hospital and Health Services Commission looking at the situation of rural health in Australia. And they identified 4 broad pillars that required some attention. Facilities and services, which were essentially hospitals and health services. Workforce, the problems of recruitment, retention and supply. Transport, which is largely around access, and the problems associated with Indigenous health. I was very influenced by this document. In fact, following that, I set about doing research in Queensland, New South Wales and Victoria. And after 20 years of considerable research, I felt that I not only had the evidence, but I had the answers. In 1998, 20 years later, I was asked as part of my inaugural address as a professor to outline my vision for rural Australia, for rural health and what was required. And equipped with all this evidence that I'd collected with great confidence, this is what I wrote, and I quote, "All citizens, regardless of where they live, would have access to healthcare services which are responsive to the specific needs of all population subgroups. A healthcare system that integrates health promotion, restorative services and continuing care, and one which maximises the scope for collaboration of health workers in multidisciplinary teams and coordinating the activities of healthcare systems. Entry points into the system and pathways of care would not disadvantage any Australian on the basis of place of residence, be it an urban, rural or remote location, and would enable continuous and coordinated patient care. Ready access to information and programs relating to health promotion and the prevention of ill health would enable citizens to adopt and maintain healthier lifestyles, thereby reducing the need for curative care treatment and resulting in improved health status of rural and remote communities. Not a bad goal, really, was it, for 1998? And I've had quite confidence that we'd quickly resolve the problems. But in fact, now I reflect on that situation in 1998, I kind of feel a bit like the chap who visited the fortune teller at the circus and sat down in front of the crystal ball. This chap was a sceptic, of course, but here was me armed with all the evidence, with the vision ready to go. The fortune teller began, "I see you are the father of 2 children. "Ha, that's what you think," replied the man. "I'm the father of 3 children. "That's what you think," smiled the fortune teller. So clearly we're a long way from achieving my vision of rural health. Some of you got that, didn't you, after lunch? So the key question in many ways is that given the wealth of research evidence on rural health, why has the problem been so persistent? Surely we have the evidence. And look at this slide here, which I've taken from work that was done and published recently in the Electronic Journal with David Lyle, just to give you a snapshot of rural research from the UDRHs in 2013. It demonstrates what David was saying about the wealth of activity that's taking place. A large number of peer-reviewed articles focusing on key aspects of rural health: workforce, service delivery, population health and other things. And of these papers, a good 40% were clearly targeting specific rural remote issues. We know from evidence over the years that the rural and remote context is very different from the urban environment and that one coat doesn't fit all. We have the geography, the small settlements, the vast distances. We know about the problems of mortality and morbidity and the higher rates of hospitalisation. We know about the socio-demography of the place and the economic disadvantage of many of rural and remote areas. And we know that socially and geographically there's great diversity in terms of lifestyle differences and that there are inappropriate ways of mainstream services and mainstream programs being delivered. So that's the first thing, we have considerable knowledge. The second thing is about solutions and policies. Well, if you go back over the last generation, there have been many strategies, policies, frameworks relating to rural remote health from the Commonwealth, from state and territory departments. We have considerable number of programs that relate to education, training, support, service delivery and so on. So we do have, in fact, a policy arena, a policy environment with many things happening. But the third thing we need is the will and the resources to implement the specific rural and remote policies that are built on the evidence from the research basis. At the moment, we have something like 45 odd, and the Canberra bureaucrats can correct me, specific programs that target rural remote areas. And collectively, the quantum is probably in the order of 1.5, if not more, billion dollars per annum, which, if you look at it as a percentage of the overall health budget, is minuscule, but it doesn't take account of many of the mainstream programs that still impact upon rural and remote areas. So, I guess what I'm asking is, to what extent are the planets aligned? To what extent do we have the knowledge, the policies and programs, and the implementation aligned such that we can start to measure the difference that's being made in rural remote areas? So in the next session, which John's going to lead, we're going to take you through systematically some of the evidence that's been collected by the Centre for Research Excellence that was funded through AFCRI and that's been done by Flinders University, Monash University, along the way to give you an idea of some of the evidence that we believe can underpin the future.
Thanks, John. This is going to be quite an information-rich session. So I just want to know, hands up, who are the researchers in the room? Okay, thanks. Who are the people that are nodding off after lunch in the room? Hands up. All right, I know who you are. I'll keep an eye out. If I see you nodding off, I'll wake you up. Lucy? Yeah. Thank you for your honesty. So, John's spoken about, and we've seen some presentations today already about the gradients as you move from major cities in Australia out to remote and very remote communities. So socioeconomic status declines as you move away from major cities into rural and remote areas. We know the proportion of the population that's Indigenous increases as you move out from major cities into rural and remote areas, and of course that population carries a heavy burden of disease. We also know that access declines as you move away from major cities into rural and remote areas. So no surprise, as John has said, that mortality rates increase in a geographical fashion as you move from major cities out into remote areas. And at the same time, avoidable hospitalisations increase as you move into, particularly into remote and very remote areas. So you don't need to be a rocket scientist to deduce that we need to really do something about our primary healthcare systems across rural and remote Australia to enable to decrease the number of hospitalisations, improve health outcomes at a lesser cost. So over the last 10 years or so, John and I, with a broader team, and many of whom are here today, have been working on a program of research, and I'm just going to give you a brief overview of some of the findings that have come out of that. So, what do we know about effective and sustainable rural and remote primary healthcare services in this country? So the first thing we did, and you can see it was over 10 years ago now, was have a look at the literature. We thought, well, you know, we're thinking about models of service delivery. People have been delivering services here for a long time. There must be plenty of literature about what services work and where they work. And in fact, the number of rigorously evaluated services was small. But we were able, out of that literature, to develop this sort of a typology of services that were both effective and sustainable and had been evaluated to be so. And it ranges from these rural services in more densely populated areas. These are larger country towns where you see GP practice type services, right through to very remote areas where the population, the small population, doesn't support a full health team, and so they rely on small numbers of resident staff and visiting staff coming and delivering the rest of the services. So we were able to synthesise a typology that told us what services worked and where they worked. The question then was, why do they work? So this really reflects what Paul Worley was saying this morning. What were the common factors across these different types of services in different places that might explain why they were effective and why they were sustainable? And when we looked across those services, both what was written about them as well as doing some detailed field work, we did some case studies of some of these exemplary services. This is what we synthesised out of that experience, that those services that worked had good governance, competent management, inspirational leadership. They had the sort of infrastructure that you need, the sort of infrastructure that Ross was talking about. Not just buildings and cars, but also information technology so that those services could monitor what they do and make sure that they are working well. They were well coordinated both internally and externally. They were adequately funded, and they had workforce. And not only did they have a supply of workforce, but they had a workforce that was adequately prepared for working in that location. And then there were a number of macro-scale environmental enablers. A supportive policy that meant that there would be ongoing funding. In Australia, we have this issue about federal-state accountabilities, and so the successful ones managed to get federal and state policies to align, and some degree of community participation. So this is what we synthesised out of that research, that both primary and secondary data, as the reasons why these services were successful. And they were successful not because they did one or two of these things, they did all of these things. There was the system worked. So then we wanted to explore some of these service requirements in detail. We wanted to have a look at funding, we wanted to have a look at some workforce issues. But the first thing we realised was we needed to understand what we meant by primary healthcare services. Not what's the definition of primary healthcare, but what sort of services should people living in rural and remote areas expect to be able to access in their communities. And it's important to see this from the consumer's point of view, because in some places people don't know what services they've never had. So again, we looked at the literature. There'd been some good work done in the Northern Territory on core primary healthcare services. We pulled together a Delphi group, and we came up with these 8 broad areas of service. And then we asked that group to tell us in which of these services and in which communities should these services be delivered by health professionals that were resident in those communities, and which would be delivered by visiting services or people having to go to the service. So don't worry about the detail on this table. The left-hand column here is a list of the services. This relates to remote communities. This relates to rural communities of different size, from small to large. And just look at the shading. And what the shading tells us, and what the Delphi group told us, was that in remote communities, there was an expectation that more services that would be delivered in communities of smaller size by resident health professionals. So you see that the shading goes down to the smaller communities, whereas in the rural communities, not so much. And that makes sense intuitively. So if you're in a remote community, you're by definition further away from services. Often there's little or no public transport, and sometimes, this is poor old Fitzroy Crossing again, you can't get in or out at all. So we looked at what models worked where, why they worked, what are the services that people should expect to receive, and then we were interested in looking at what those services should cost. We did a number of exploratory studies. This is one of them, where we looked at trying to work out some benchmarks for remote primary healthcare services. So this is remote primary healthcare services. We identified some high-performing services, got some detailed data from them, and developed this predictive model. And the detail isn't that important, although the new knowledge that came out of this particular study was that there was a baseline of funding. Sorry, I'm just trying to use this thing. Okay. So there was a baseline of funding and then a per capita sum on top of that. And that, when we looked at the literature and discussed this, that made sense too, because what it meant was you needed a certain level of funding to make sure that there was a safe service there. So, for example, in the Northern Territory, there aren't any single nurse posts anymore, so you have to have at least 2 nurses, probably a couple of health workers and other staff. So we did some work on what they should cost. And then we were interested in workforce retention, and so we collected some national data looking at actual workforce data from different health services around the country. And I just want to show you one of these, or highlight one of these. So these are the different professional groups. This is remote, this is rural, this is remote over here. So if we look at the remote nurses, the median survival of that sample was 3.5 years. So if you start with 100 nurses, recruit 100 nurses, after 3.5 years, 50 of them are still working for that service, okay? The 12-month survival probability was about 80%. So after 12 months, there are 80 of those original 100, and after 24 months, about 2/3 are still there. This is some very recent work that we've done. This is just in the Northern Territory, looking at all of the remote clinics, government clinics, and what we found in this study was that the annual turnover was 148%. 148% per annum. If we look at the survival, the benchmark previously for median survival was 3.5 years. Now it was 0.3 of a year, so an order of magnitude difference. So if you start with 100 nurses in a clinic, after 4 months, half of them are gone. Not dead, they're just gone to work somewhere else. So there's a real problem with workforce stability. And so we've started talking to some of the health services, and there's a lot of interest both in government and community-controlled health service, about looking at what we can do about stabilising the workforce in terms of retention strategies. And Leslie's not going to allow me to go into any detail here, but to summarise, what we really need, what the literature tells us, we need a bundle of short-term strategies. There's no silver bullet. But if we do these things here, then we're more likely to retain our staff. And in the longer term, we need to look at health professional pathways, and I think we can use the integrated rural medical pathway as a model for other health professional groups. We've done some work on community participation. Here are a few of the papers that we were involved with. In brief, there's a growing literature around community participation and its impact not just on acceptability of services, but also on health outcomes. And we've done quite a bit of work on developing monitoring and evaluation frameworks for both rural and remote services. And we know from international literature that if we can improve primary healthcare access, we can get better health outcomes at a lesser cost. And this slide refers to a couple of cost-effectiveness studies that we did in the Northern Territory. The first one was looking at diabetic patients, quite a large sample of diabetic patients. And when we compared those with low access to those patients with higher access, there was a very significant decrease in hospitalisation, decreased death rates, and of course it was cheaper to deal with diabetic issues, problems at the primary care level rather than those people being hospitalised. And when we looked at 5 chronic diseases, diabetes, kidney disease, heart disease, hypertension, and lung disease, we were able to calculate that the high access group relative to the low access group saved the NT government $125 million a year in terms of the costs associated with hospitalisation. So these are not trivial amounts. So that we know from both international and local literature that strengthening primary healthcare services will provide better outcomes at a lesser cost. So we've got quite a bit of knowledge now about how to provide services, what those models should look like, various features of those models. The question is, how much of this has actually been implemented, and what should where do we go from here? So I'll hand back to John now.
So this was the situation in 1976. In 2018, when I started to look at all the reports that were coming from stakeholders and RFDS and the ABS, how would you summarise the rural health problems? Well, again, 4 headings: funding and infrastructure, workforce supply, access and Indigenous health. Very similar, but in fact different, because over the 40 years, considerable things have happened. But the nature of the problem is different today. Where there was a workforce shortage many years ago, we don't have a shortage now. The problem is much more distributional, and it's much more in terms of preventing avoidable turnover. We have considerable infrastructure, but we don't necessarily have the right models. So that's the situation today. So the question again, why are the problems so persistent? Given that John has outlined that we've systematically looked at the data and the issues to understand the nature and causes and scope of the problems, why do they persist? And I've taken 3 quotes here. One from John Maynard Keynes, about the problem of decision making if you have lots and lots of facts and evidence. Donald Trump wouldn't like that one. Col Owen, one of the stalwarts of the rural doctors movement many years ago, very insightful person. identifying that those above the coalface that were not hearing the research. These were the sounds of silence, he called them. And a senator, during the presentation that I made to the Senate Commission, that bureaucrats seemed very closed to the fact there was any problem with the existing system. But it's not all bad news. I want to demonstrate that here are 4 examples, and we'll rush through them for you, but 4 examples where evidence has been translated into meaningful policies and practices. Changing resource distribution, in terms of providing education and training resources that are appropriate, in terms of safe workplace practice, and in terms of medical education. So I'll just briefly look at the modified Monash problem. So what was the problem? Well, the problem we had was that the government was spending $134 million a year giving incentives to doctors all around the country. And the media and the national groups were advocating that the basis on which this was happening was simply not equitable. You had doctors in Townsville and Bendigo getting the same incentives as the doctors in Brewarrina and Borroloola. And this didn't seem appropriate. But there was really a lack of evidence around what was a better way of distributing the dollars and who should get the money. Well, and I want to pay tribute here to the work of Dr. Matthew McGrail, who's in the audience, who worked with me on this. What we did is we did an analysis of data relating to general practitioners in terms of what they did and the circumstances in which they did it. So we took 4 professional indicators relating to their work practice and 2 non-professional indicators that related to spouse and family needs, and we mapped these against community size, against the geography, to see what was happening. And it was very clear that if you combine community size with remoteness as a surrogate for these procedural and practice activities, you could get a better classification. So when we did the statistical analysis, it was a much more sensitive classification we developed. And we developed a 13-level classification, but of course policymakers don't like too many groups, so it was brought back to 6 and ultimately to 7. But you can see the significance that we found in terms of the association was quite strong. So the problem was solved, wasn't it? Here was the classification scheme, much more sensitive to important differences, and it was much more equitable. More dollars were going to those doctors who were doing more complicated procedures in more remote and disadvantaged locations. End of story. We published that research in 2011. It was adopted 5 years later. So fast, indeed. Gone is incremental change, Lucy. And here is some of the situations we had to do. It wasn't just the fact that the publication exists. We presented to a Senate committee. We made a presentation to a Senate committee at our cost. We made presentations to the Department of Health. There was the Mason Review that had a look at this. We presented again to the department, and they analysed the stuff and took the data and permed it. There was a presentation, there was a technical advisory committee, and then we had a change of government, didn't we? Then there was the GPREP independent advisory panel that looked at this, and ultimately Fiona Nash announced this at the Rural Medical Doctors Conference at Akron about 5 years later. So you can see here that there was a great and onerous process, time-consuming process. And the point I want to make here is that your university will not congratulate you or reward you for this. They will for the high-level peer-reviewed publications, they will for the dollars you bring in, they will for the PhD you graduate, but the work that underpins changing outcomes will not receive the same recognition unless you can patent it or commercialise it. So what are the key ingredients? What can we learn from this one case study? Firstly, you need rigorous research, and that doesn't happen overnight. Secondly, transparency is important. Okay, unlike the Trump administration, this is the way it happens. You need to put your results and your data up for validation and amplification, and the Department of Health people work through this meticulously, hence the modified Monash model. The relationships with end users. Over the years, John and I have spent many, many hours with the advocates, the stakeholders, the communities, building trust, convincing them that we're there for the long haul. And there were multiple modes of communication. Not just 160 characters, but all forms of written communication for people of different intellect. Lessons for the future, the timing is important, okay? Make sure your bottom drawer is full of all the answers that emanate from your research. That it's not research waiting the problem, rather it's research awaiting the problem rather than the problem awaiting for the research. And you have to be patient and you have to be persistent. So there's one example of research evidence underpinning something that's quite significant. Let's look at a second example now, and John will take you through this one.
Lucy, stand up. All right. No, that's okay. I just want to make you up. So, CARPA, the Central Australian Rural Practitioners Association, was a group of health professionals in Central Australia that got together in the late 80s. Sabina, where are you? Okay, stand up. One of the few still around, a few founding members still around. This was, there were no UDRHs, there were no clinical schools, there was nothing. So this was an organisation that got together to look after one another, to do their own professional development, to organise. They organised conferences, there was a newsletter, and the other thing they did was develop the CARPA Standard Treatment Manual. So this is a book with clinical protocols for treating common presenting conditions in the Northern Territory. Why? Well, because this is what the remote health context is like. There is a high staff turnover. You've seen the sort of turnover that we have currently. A population that's pretty sick, mobile, staff that are working in an extended scope of practice in an isolated fashion and often not very well prepared for the job. So we wanted to standardise these treatment protocols to ensure consistent, best clinical practice for remote areas. And that may be different to what you might do in a metropolitan area for various reasons. And so the first CARPA Standard Treatment Manual was published in 1992. This was a small book that fit in the back of your back pocket. And since that time, it's grown in size. We now have a suite of remote primary healthcare manuals. And the CARPA manual has been evaluated 4 times, rigorously evaluated 4 times now. The evaluations were all very positive. The users see it as a credible document. It maintains clinical and contextual relevance. It has an incredibly high compliance. I mean, the fact that a clinical guideline or protocol is used is unusual because most guidelines are never used. This one is used and the compliance is very high, in the order of 80+%. It's now been embedded in policy of all health services in the Northern Territory, all remote health services. It's used in orientation and training of staff. We use it in our master's program. It's enshrined in legislation. And so it's widely used and is really part of the landscape. So why has this been a successful piece of research translation? Well, I mean, it's scholarly work. These protocols are reviewed on a regular basis by content experts. It's then rigorously reviewed by context experts. So not only the people that are a full bottle on that specific disease, but also the people that will use the protocol to make sure that it is used. And I think that makes the big difference. It's also embedded in policy training legislation. And it's really been an exercise by the end users for the end users. And I think that's at the heart of its success. I'll hand over to Sue.
So this was a piece of research that John was chief investigator and Sabina was involved with, and a few other people. And it looked at, we were trying to improve our understanding of workplace stresses in the remote work nursing workforce, and we wanted to describe the stresses and measure the levels of occupational stress, but we also actually wanted to make a difference, not just describe the problem. So part of it was to develop, implement and evaluate actions that would reduce and prevent occupational stress amongst RANs at a systems level. So we weren't looking at individuals, but we were looking at changing the system within the Northern Territory Health Department and one of the others to reduce the impact of stresses. So we did a national survey to all registered nurses in very remote Australia, and that involved developing a database of all remote health facilities that employed nurses, and then ringing every one of them. And then we worked on participatory action research just with very remote Northern Territory, and then we repeated the survey nationally using the other states as a control group. So we had process evaluations were very positive. RANs in particular appreciated the opportunity to brief and to have input into changes, and the least powerful actually gave the most positive feedback. The outcome evaluations was a little bit disappointing in that we didn't really see any changes in job demands or any increases in job resources. And there were a few actual interventions implemented in the time of the project. So the intervention stage was 12 months, which we found is just too short. You need longer than that. But they have been continued to be implemented since the end of the project, but very slowly and haphazardly until the murder of Gal Woodford. She was a nurse who was a graduate of our program, certificate in remote health practice, who worked in northern South Australia. Some of you might have known her. So after the murder, there was suddenly a massive increase in pressure by the media, by remote area nurses, by the public, upon the politics and health services. There was a RAN safety petition that gathered 130,000 plus signatures, and Gale's Law, some of you maybe are familiar with that, in trying to make sure that people don't, or remote area nurses don't attend call-outs on their own. So we had evidence-based solutions that really, tragically, we had to wait for the problem to come up. I wonder if I've got, and that's Gal Woodford. And just a point I'd like to make is, I think the situation of remote area nurses going out on call on their own at night has been standard practice for years across Australia, has never been safe. And really there was a level of irresponsibility by a lot of health services, by managers, by RANs ourselves, and we'll have said that, to allow that situation to continue. In a lot of places in the Territory, it has really changed. Most places have first responders now, or second responders. Some areas of Australia still don't. But it was interesting, it wasn't just that one intervention that was taken up from that research, it was quite a number. Thanks.
Thanks for that work. I'm trying to have a PowerPoint-free zone for my tenure as National Rural Health Commissioner. Just humour me. I hope I succeed for your sakes. So I thought I'd give an opportunity just to look at, for those of you who are trying to turn your project into a program, or your program into something that can work for others around the state, the country, the world. The experience that I and colleagues have had of doing that with the medical education program, as John pointed out, without a workforce, all the other things that we try and do in a rural community to have a sustainable service just collapse. So the project was to look at an educational approach to creating a workforce. In this room today, you probably will take for granted that, of course, a person can study any health discipline based in a rural community. For medicine, they can undertake their whole course in a rural community. That wasn't the case in the 1990s. It was seen as a privilege for rural communities to request 2 weeks of the entire 6-year medical course for a rural experience. Some went to the extent of 6, and that was seen to be extravagant. But it was a risk because you were never sure exactly what you would learn, if you would learn anything. And in actual fact, it didn't matter because you learnt what you needed to know back in the hospital. So just go and have a good time. So how have we got from a project to a common understanding that that no longer is evidence-based? So it started with a very small group of colleagues. Choose your pilot site to be a site that you know well, that you have relationships with, that you have some, as John Humphreys was saying, you have some credibility already with that team. And as we heard before in terms of the researchers, that integrity, that sense of spirit and purpose, choose your site carefully with that. Then look at this as an opportunity for research that can inform others, not just a way of proving whether it worked. Right from the outset, the advice I was given was do this as a PhD. Use that level of rigour in the work that you're doing rather than just collecting enough evidence to get another funding grant. Look at this evidence being at 2 levels, and in this way respect the audience of your research in the methods you use. Within the medical school, to enable this to survive more than 1 year as an experiment, and we branded it as an experiment, we had to show that the academic results were at least as good as the students who were in the tertiary hospital. First do no harm. That actually wasn't what we were interested in as researchers, but we had to do that in order to respect the audience of people who were also interested in this project. So we needed to use some quantitative data that would give us very initial evidence in that regard. We then also needed to say who else is going to be interested in this project. If other people are going to look at this, they're going to want to know how and why. So there are how and why questions that we needed to use qualitative approaches, particularly the perspective of the students and the supervisors. And Lucy's research extended the perspective of the supervisors. Again, thinking about what people would need to know if they were to want to take this up. Action research, to my knowledge, participatory research means that you're blurring the boundaries sometimes between who is the subject and who is the object. And from the perspective of this research, allowing the subjects of research, the supervisors, the students, to be interviewed by as many people who were interested in what we were doing, rather than them just coming and talking to me, come and talk to the subjects of the research themselves and gather your own evidence about its impact and effectiveness. I'm sure that they were the stories that Lucy was talking about. It's the opportunity to allow others to come in and participate themselves, if you like, as researchers, in forming their own views of that subject. And we have had so many replications of this program that have occurred by people coming and not talking to me, but coming and talking to the doctors who are supervisors. They want to know how it worked in the practice. Talking to the students. How did it feel for you? Why did you do it? What were you worried about? What made it work? What didn't? Not just what we wrote in the research. So open up your research laboratory to others to come and conduct their own inquiry, not just rely on your papers. It doesn't diminish the opportunity for you to publish, and it's more likely to get you citations when you do, because they're going to want to look at what they have also looked at themselves. They won't steal your intellectual property. So one of the big issues that we face is, well, whose intellectual property is this anyway? If I've been a researcher in what is essentially an action research, is it my intellectual property? Certainly this project has expanded far more rapidly because I haven't viewed it that way. I viewed this as a common good, as a public good, and just as much property of the participants as myself. Involve the students in research and the subjects, get them to do their own research papers as a result of this. One of the papers that I'm most proud of, we published in 2001 in Rural and Remote Health, was published by one of our students who said, I want to know how long it takes the doctors to do this stuff and whether they're losing money on this. So she published this neat little paper that then was the pilot for Lucy's research that went on and did this in a very methodical way. But that came out of a student doing a student project. The two other things I would say. Firstly, don't be scared to get the person that you think is going to be your most severe critic to be a colleague in your research. So when we started this, we actually got Adelaide University to come and be part of the evaluation. And for those of you who know Flinders and Adelaide back in the 90s, it wasn't necessarily a bed of roses between the two institutions. So we got the people we thought would be our greatest critic to be part of the research, because we knew if they said it was working, everyone would believe it. If it was only us, we wouldn't. And secondly, allow the political process access to your resource. So Jack Best was one of the key people that went around to multiple researchers and allowed politicians, including Michael Wooldridge, who came and visited us, and allowed them again to ask their questions and say, well, how big could this be? It very quickly morphed from a $150,000 per year program to $250 million that we now see invested in rural clinical schools and many more millions across the world. If you think of those principles, your project can turn into a program, can turn into, well, it was always that way, wasn't it?
So we've had a considerable amount of discussion now of examples of research in practice. Bob Wells will now lead the next session, I hope. Go back. Can you put... Help, Frank. Just the last slide. Thank you. Okay, Bob.
Okay, well, I'm going to hardly talk at all. This is a session where we ask you to tell us some of the answers. But I might ask some of the questions. We haven't got the questions yet. Look, just before I do, I just want to talk a little bit about... I think the objective of this session was to show what's been done, and then to talk about, well, where do we go from here? What more can we do to make change in the system that will be positive? Because the current change, as John Humphreys' slide showed, over 40 years we tried to tackle the same problems that we started in 76. We're tackling largely the same problems in 2018. But I want to talk about two things about policy. My background is in policy, which is good because you don't really have to do anything specific in policy, just wait for an opportunity to arise. But there are two stories in this. Count Bismarck, does anyone know who Count Bismarck was? He was the German Chancellor in the late 1890s. And he talked about policy. He said, the product of policy is like a sausage. Sausage is fantastic, Germans like sausages. But you never want to watch the process of making a sausage because it would really turn you off sausages and then the whole industry would collapse. So policy is a bit like that. It's hit and miss and it's random and it's sometimes inspirational, not very often. The other story I want to tell is we have had in rural health long periods of what I call incremental change, and we've seen that over the past 20 years or so. There have been good change, and we've had a lot of it presented at this session. But occasionally you get what I call transformational change. And a lot of the incremental change we've had in the last 20 years was from a transformational change which occurred in the period 1996 to around 2000. And that was when we had a change of government from the Liberal Nationals have been out of government for, I think, 15 years or something. And then they thought they'd get in an election in 1993, but unfortunately their leader, John Hewson, couldn't tell you what it would cost, what the GST would be on a birthday cake, because it was his formula for it was so complex. So it fell over, and I think that almost destroyed their chances of winning the losing the unwinnable election. Losing the unlosable election. Thank you. So clearly the lessons I draw from that. And somebody mentioned Jack Best, and I think we owe a lot actually to Jack Best for... Jack in many ways was a difficult character to work with. Some people found it that way, of course I didn't, but the reputation was Jack could be a little difficult at times. But Jack was the one really who inspired Michael Woolridge, I think, really, to do something serious about workforce, to do something serious about rural health. And the key things he did about rural health were setting up the current educational research structures that we have, the UDRHs, the rural clinical schools, and the research that goes with them. So that was a period of transformational change. And we haven't had a period of transformational change since then. We've had a succession of governments, and particularly a succession of prime ministers, but we haven't had a lot of transformational change in the health system. In fact, I think we've had very little. So what I want to talk about is incremental change will continue, and if you keep doing your good work you're doing, and that will happen. But I want to look at these questions here. We know a lot now from our rural health research, particularly which has accelerated over recent years and will continue to accelerate, I think, given the quantum of researchers we have and the skill base they've developed and the strong reputation that they've developed as well. But so is it time, is there enough evidence now to perhaps, and we have an election coming up, a federal election coming up in 12 months, and the two major states have elections coming up, one later this year and one about this time next year, Victoria and New South Wales respectively. And the federal election presumably will be sometime shortly after the New South Wales election, mainly depending on how that election goes, I guess. But is there opportunity to develop and suggest some transformational change that we would think would be important to lift the thing to another level, not just incrementally go up? So that's the first question. Based on the evidence we have, what might be some opportunities for transformational change? Don't put your hands up yet. Second question is, do in fact we now need a national rural health research implementation strategy? We've accelerated the rate of health medical research in rural areas, but we don't really have an implementation strategy. How do we draw all that research together and say, well, here's how we might tackle the workforce or the access or whatever it is we might tackle? And then if we wanted to do that, what process resources would be needed? But the first two questions, I think, are the ones I'd like to explore with the group this afternoon. I don't know if any of the panel has any comment on that or anything they'd like to add to that before I hand it over. So all those who are asleep can now stand up again. No, I was only joking. So let's go back to those four issues that John Humphreys identified for 2018: funding and infrastructure, workforce, access, and Indigenous health. So are any of those areas ripe, if you like, or all of those areas, or some of those areas, ripe for a transformational change in the system that would lift it up to accelerate as we've done since 1993? Question. Yes, ma'am. Oh, you got the microphone. Who's got the microphone? No, you stand up and talk, please. Thank you.
So it's Jo here from Queensland. My question is got nothing to do with what you just said, sorry, but
That's okay.
It's a question anyway.
I was just rambling anyway.
So I'm just sitting listening, and I think I've been part of some of this research, not being being one of the interviewees on some of the work that's been done, some of this group. But I'm sitting and listening and thinking, comparing and contrasting with the work that's been going on with the National Disability Insurance Scheme, and thinking about some of the commonalities of fractured service provision and poor health outcomes, and some of the disadvantage experienced within, people with disability in Australia, and how I don't know whether there was a lot of evidence and whether there was a lot of research of, that underpinned all of this. I actually don't really know the answer to that question, but somehow or other, with community will and with political engagement, we managed to get a once-in-a-generation change of a system that's, really gone into blue sky thinking and is recognised around the world. So I'm just, reflecting and thinking, why do we need to think of it in little boxes? How can we just transform the whole lot in one go? I don't know. If we can do it with the National Disability Insurance Scheme and change a whole system, can we do that with remote health?
That's a good question. Anyone got...
Can I respond to that briefly?
Yes, yeah.
Look, I think that's the crux of it. I guess what we're saying to you is, we've presented just some of the research, a summary of some of the research that we've done. The previous panel that was here, there's a whole programs of research that came out of the people sitting here in the panel prior to us. So there's a lot that we know. If you were to say to me, what would a good health system look like, I could tell you, because I think we've got enough information. So your question is the crux of it, and that is, how do we go about facilitating that change?
Yep, over there.
Scott Kitchener, Griffith Rural Program. Look, we shamelessly plagiarised Paul's work as well, and developed a long look program which I think we had to do apologetic research for. We had to demonstrate our academic equivalence. We had to demonstrate that it had workforce outcomes. We had to demonstrate that it didn't cost any more, that it didn't damage students, which was a claim. Then we have a contract that tells us to do research that demonstrates the efficacy of our program by evaluating it. We have to do research that's relevant. I think this is apologetic research. I think one of the problems that we've got is that systematically rural health workers don't do research because that's what we do. If you go and work at one of the major hospitals, if you want to get ahead, then you just do research. That's what health professionals do. I don't think that we're at this stage considering that you come rural, it's incidental that you're rural, you should do research because that's what we do. If you're going to do research, then obviously you do something that's relevant. But I'm interested in whether or not, or when the panel thinks, that we're going to make that leap to research is just what rural health professionals do in the same way as all health professionals do, rather than we do research because we need to demonstrate that we're as good or that we validate our existence as health professionals.
Happy to take that up. In simple terms, if you look at the vision that I have for rural health services, they need to change from essentially just concerned about service and essentially being locum-led health services to locally led learning health services. Why? Because we know from around the world that the best health services are those that integrate clinical care, teaching and research. And yet somehow we've come to accept that that's okay for the city, but in the country we will just do the service bit and we'll take the teaching and research that is done in the city. And with exceptions, there are always exceptions that prove this rule, and there's been investment in researchers, if you like, out of that system, and some like Ross and Leslie have managed to come back into it, but there hasn't been the expectation that as clinicians we are also researchers and teachers, just as part of our work. If we're looking for that transformation that needs to occur, what happened with the NDIS was the locus of control changed. The locus of control changed from organisations that relied on people staying disabled for their their business to people who were living with the disability being able to choose what help they need. Now, if we're wanting that same transformation in rural health, in education and in clinical service, what is the locus of control that needs to change? I would suggest that we learn from, as I said earlier, from our Aboriginal brothers and sisters, that it's the community need to be in control, and that's the rural community need to be in control. And at the moment, for our health service budget allocations, for our education allocations, for where the education occurs, it's all driven from our cities, and we are outposts and regarded as such. Some are good outposts, but we're still outposts. So is the opportunity for there to be a transformation? Absolutely there is. If we're prepared, and if someone's prepared to support us to move that locus of control.
Another comment here.
Got the hands going up.
Hi, I'm Fiona Brook from Sarah. I'm asking, I think it's mostly for Paul, but it's really for everyone. We talk about moving the locus of control, but we don't have things like cultural safety embedded in our best practice guidelines on how to manage various conditions. And we seem to have a system that's more inclined to measure throughput than health outcomes. So what can we do to change that? Because, I mean, even just looking for... We don't have a lot of evaluations of the big programs that are out there. They tend not to be done. So how can we change that? How can we actually get government to be part of the solution as well as the funder of the solution?
Could I... Oh, do you want to comment on that, Paul? Or?
Yeah, I'll just say that I think that's a problem for cities as much as rural areas. But I would be really interested in Bob's comments.
Yeah. Well, I think Paul's point is right on the button about locus of control. And at the moment, the locus of control is in Canberra, it's in Sydney, it's in Melbourne, it's in Adelaide, it's in, it's spread around the states and the Commonwealth. I worked in the Commonwealth. I never worked in a state. And I always thought, oh, well, I didn't know anything, but at least the states would know. I quickly found out the states didn't, in fact, probably knew less than I did because I actually talked to people. So I sort of thought, well, nobody knows anything. So I used to work as much as I could with the people who were actually delivering the services or doing the research or whatever they were doing to get a feel so I could give better advice to the government. And I think if we had... I mean, I've got an idea about how you could radically restructure the funding of the health system, but that's not my job today to waste your time on my view. Well, what I would do, I mean, I think we have... do you really want me to tell you that? Yeah. Okay. All right. Have we got time? We've got 1 minute. At the moment, the health is largely funded through pipelines, and there are more and more pipelines as we get more ideas. There's a cancer pipeline, there's a mental health pipeline, there's this pipeline, there's that pipeline. So what you get down at the bottom end, sorry, at the delivery end, I don't mean bottom in a judgmental sense, is you've got all these reporting requirements which are coming from perhaps different agencies, different parts of the agency, different people have different expectations, don't know what they really want to achieve, so you get these obscure sort of reporting and targets and all sorts of things which are impossible. So you've got to pull all that together and deliver an actual service to people who have, most of whom have most of the conditions that have come in pipelines, but it's not funded that way. So what I'm thinking, and I'm picking up Paul's point, I would devolve a lot of that. I would have the pipelines going to primary health networks, suitably reconstructed, suitably governance changed to be community governance rather than professional service delivery governance people. And you're competent to actually receive the money, deal with the money properly, understand their communities. And for some of the big areas, of course, they'll have different needs in different parts of their area. But let's face it, a lot of local governments have that same thing, and they have this sort of problem in that part of the government area, that problem, and they have to work through that. So I would actually take the money, give it to the PHNs, not overnight, mind you. This would be a bit of an iterative process. And I would say, well, you're the ones responsible now. You're run by the community. You're not run by the health professionals who happen to work in that community. Not that I'm trying to put health professionals down, but it's the community who have the need. And it's the community who should decide in any democracy, I think, what the priorities are and how those priorities should be tackled. So that's my lesson for the day, for anyone who's interested. Yeah. Leslie's next, I think, yeah.
It's Leslie. I actually believe the death knell is putting an implementation strategy up there. It will be a policy paper that sits on a shelf that, like the other policy papers, make no difference. We are talking about locus of control, but I feel very positive about locus of control. I've just come from a local health district for a large population, large Aboriginal population, where you have the primary health network, the local health district, the AMS working together on decisions about delivery of healthcare. The local health districts have appointed a director of research as part of their very scarce budget because they believe research matters and is important. And I actually think the locus of control shouldn't be with researchers, it should be with the clinicians and the policymakers with whom we do research to meet the needs of their problems. If they're partners with us, if they're part of that research, they own it. We don't have to tell people about research. They own it. They shape it. They help us do it. Therefore, they implement it. So we are down to locus of control. We're down to regional, local locus of control, networking, and that will make the difference, not this nonsense of the stuff at the top. We've got to actually come from the bottom up.
Janine here. Is that all right? Can I go next? Is that okay? Cool.
You got the microphone, you go
I've
next.
got the microphone, I've got the talking stick. Janine here. So I think what Leslie said is partially true. I mean, I'm not sure who should be the fund holders here, but what I learnt from going to the Dublin, the World Health Organisation Human Resources Conference, was that millennials do want to have mobility, that the locus of control needs to be in the next generation of people that are going to lead our communities in rural communities with our rural communities. And the nomenclature around that has to be about the greater good, and I'm really, you know, the dichotomy that we set up by talking about urban and rural all the time is really unhelpful, because I think the policymakers need us to help them with the language that is about empowering our communities to be stronger and wealthier, and the whole of Australia actually does better. And I don't want to buy into the whole neoliberal discourse, but actually it is about a stronger, more economically stable Australia. If you've got really good rural and remote communities, we'll be much better off. If we've got really healthy and well Aboriginal communities, we'll be better off. We'll have their rich culture being able to lead us into the next millennium. You know, I'm really passionate about that, and I think it's very much about the language we choose and getting youth involved in making a movement that sings.
Yep. Oh, someone, sorry, microphone over there is next.
Can I just
Oh, sorry,
say
yeah.
something? A lot of this I actually don't think really matters unless we have stable, well-functioning primary healthcare teams on the ground, which we don't have. And that's pretty well, if you have a look at the turnover rate, particularly amongst remote area nurses in remote communities, I just think that's a dismal situation that we have 148% turnover. And until we do something about that, none of the rest of this is really going to matter too much.
No, but the point is that that's linked to all those other factors. It's linked to governance and whether there is, you know, some community control of governance. It's linked to good management. It's linked to reasonable funding and so forth. So you really need to address it in a system. You need to address the system rather than a component in the system. Can I?
Yes, John.
Can I just refocus this? I want to put Paul on the spot. No. I want to give Paul an opportunity to have another comment. So, you know...
We've got 7 minutes.
We don't need afternoon tea. Maybe Lucy. You know, there's as I was saying, there's a growing literature around, you know, structured community participation. There was a review of the Victorian health system not long ago, King's Fund did a review of it. They said they've got a system that's as good as any. It's very efficient because of activity-based funding. And one of the factors that they identified was that they had community boards, and they had longevity. They had longevity. Now, I've got a particular view of what a good primary healthcare system should look like in Australia. I think some of us share that view, an integrated regional structure with community governance. And in fact, in the NT, a few years ago, we got that. Where, you know, as a result of the healthcare reform, we got 2 regional health services with integrated primary and secondary care and community boards in each one of those. There was a change of government, they sacked the community boards. So the problem, you know, we do have this federal-state problem. So we have the potential for creating a system that suits Australia, both metropolitan, rural and remote Australia. But we've got these bloody 2 levels of government that get, and the states keep getting in the way. So, Paul, my question is, in your role, let's say in your rule, I get that the rural generalist needs to be done, but then, you know, you'll have a week's holiday when that's all done and get on with reforming the health system for rural and remote Australia. How do we address these sorts of issues, these barriers like state, Commonwealth responsibilities? We've got examples both on a jurisdictional level, at an individual service level, of really exemplary services that get the cultural safety right, they get the locus of control right, they have community control, you know, we've got really good examples. How do we get those sorts of services right across rural and remote Australia?
I'll take that as a comment. No, okay, I'm better.
We can do that if you like.
No, look, the issue of Commonwealth state government relationships is integral to implementing a national rural generalist pathway. The issue of locus of control is integral to implementing a national rural generalist pathway. The issue of research translation and informing governments, policymakers of that evidence and how that can be implemented is integral to the implementation of a national rural generalist pathway. My strategy in this is to give some confidence to the governments that they can do it. There's nothing like the confidence of having succeeded in implementing something to think, well, what else can we do? We've had that seen in communities where they manage something collaboratively that may appear small, and they then say, well, what next can we do? So my strategy in this is to reflect that the people who are in government are good people. Now, you know, Bob, you were in government.
I was a good person, yeah. Might not be. No.
I rest my case, but we have this tendency to say and we had those quotes up before, and I know it's easy to get angry at faceless people in buildings, be they state or Commonwealth. But when you go and talk to those people as individuals, they are good people who all want to see success and are as frustrated as we are by the barriers that are there constitutionally. Now, we're not going to change the Constitution, but we can empower not only the communities but also the people who implement policies to see that they can succeed. Part of this is an aspirational thing. Part of it is, well, I'm never going to be able to work with those state people because they're going to blah, 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 blah. Well, you never will work with them. My sense is that the National Rural Generalist Pathway is something that is achievable, that can be a win for a certain segment of the health workforce, that can then prompt wins in other elements of the health workforce, that can then give confidence that we might be able to do more things across state and national barriers, irrespective of which governments are in power at different times. We need to develop a confidence as a nation that our government isn't our problem, because if other nations look at our government process, a lot of them are very jealous. And you just have to look around the world to see that there are worse systems, so be careful what we think of. If we look at a research-informed policy, well, the extermination of the Jews was a research-informed policy, constructed by researchers in a certain policy environment, supported by government in a certain policy environment, and meant that philosophers like Polanyi started really questioning the value of science. So we have to be careful what we think about in those extremes. But we can, I think, be confident that if we can put wins in place time and time again. Hugh, you mentioned it. If we can do this in eyes, we can do this in other areas as well. We can have the confidence. So that's the way I'm, first of all, working with the legislation which says this is what you have to do first. Secondly, I actually believe that that was a good strategy that was put in place to get something done, achieved, that all of us can be proud of, and particularly the people in government can be proud of and can think we could actually do more than this.
Thanks, Paul. Look, we're going to have to wind it up now, and I apologise to everybody who didn't get a chance to say something, but I had the feeling, there's a feeling across the room that it is time perhaps to look at something more transformational and along the lines we've been talking about. One thing I want to say is just from history, the most transformational thing Australia has done in a policy sense in the 20th century was introduce Medibank, the original Medibank. They went from zero. We had no national health system in early 1973. By the end of 1973, we had an up and running functional Medibank system, which is pretty much Medicare system now. Payments were made, they'd done the computing, they'd done all the work. So that was all done in about 9-10 months. If we could have done that back in 1975 under what was allegedly one of the most dysfunctional governments we've ever had, we can certainly do it now, I think. So look, I'll have to wind up now. Thank you very much. I'll take that as a yes from you, from this group, that there is a need for some significant change. Thank you.
Thank you, Bob.